Hello, this is the informational seminar for Southside Regional Medical Center's Metabolic and Bariatric Surgery program. My name is Dr. Datta. I'm the Director of Minimally Invasive and Bariatric Surgery here at SRMC. A little bit about me. I went to medical school at Temple University in Philadelphia. I completed my residency at Albert Einstein Medical Center, also in Philadelphia, during which I did a clinical elective in bariatric surgery at the Cleveland Clinic, followed by my fellowship in bariatric surgery at Johns Hopkins University. Today you're here to learn about your journey towards living a healthier and longer life. Why are we overweight? We can blame this gentleman. This is the Geico caveman. Back in his day and age, food just wasn't available. We had to run after our food, pick it off of trees, escape predators, and live through harsh environments. So only those folks that were able to store calories in the most efficient way possible, which is in the form of fat, were the ones that survived to pass their genes on to the next generation. Food has also evolved, but not in the greatest way. Your average burger is getting larger. Candy bars are getting bigger. Even when you go to the movie theater and get a popcorn, these are all hundreds of calories that your body has to do something with. Otherwise, they're getting converted into fat. Why am I overweight? It's simply a matter of arithmetic. If you're eating more calories than you're able to burn, you're going to gain weight. And if you burn more calories than you eat, you're likely going to lose weight. 1 pound is approximately equal to 3,500 calories. So if we increase our caloric intake simply by 100 calories per day, as seen by the red line, you can see that over a long period of time, you can easily gain 100 pounds just from that small increase in your daily caloric intake. What is obesity? Obesity is a condition characterized by the excessive accumulation and storage of fat in the body. And the way we measure obesity in medicine is by calculating the BMI, which is the body mass index. It is a ratio of your weight over your height squared. People that have a normal weight have a BMI between 18.5 to 25. Overweight goes from 25 to 30. Obesity starts at a BMI of 30 and goes up. The reason why Class 2 and Class 3 obesity is highlighted in this slide is because these would be the candidates for weight loss surgery. We've all heard of this term called the obesity epidemic, and these maps show what that means. Since the 1980s, when the NIH was collecting this data, only about 10 to 15% of the US population was considered obese or had a BMI above 30. Since that time, you can see on these slides that in much of the population, 30% or higher percent of the population had a BMI above 30 or is considered obese. There's multiple causes for obesity: genetic, environmental, cultural, medical, and psychological. There's over 200 genes involved with how we process food and burn food and store those calories in our body, so we're far from having any magic pill that's going to fix this problem for us. Environment plays a huge role in obesity. In everything we do, there's decreased physical activity. Technology has allowed us to have that comfort, but at the same time, all these calories are easily available around us that our body has to eventually process and do something with. There's cultural differences in terms of body image. Socioeconomic factors play a role, as well as psychological factors. So what are the medical issues related to being overweight? And many of you probably have some of these conditions. Pulmonary issues such as sleep apnea, obesity, hypoventilation syndrome, heart disease, which arises out of diabetes, high blood pressure, high cholesterol. This can also lead to strokes. Fatty liver disease is one of the main causes for liver transplants. Pancreatitis, cataracts, increased pressure in the fluid around the brain, gynecologic problems and infertility, joint issues, venous stasis, skin problems, the list goes on and on. One of the often overlooked problems related to obesity is cancer risk. Having a BMI above 40 increases your risk of developing cancer by 50% greater than the general population. So what are the treatment options? You've got behavior modification, medications, and surgery. Behavior modification includes diet and exercise. Unfortunately, if diet and exercise worked, we probably wouldn't be seeing the maps that we saw just a few slides ago. Since I first made this slide, 2 of these medications have been taken off the market, both for medical complications related to their use. The take-home point from this slide is you have to weigh the benefits of the medication, which is the weight loss, with the cost, not just financial cost, because many of these drugs are not covered by insurance, but also the health costs related to taking some of these medications. In general, if you just needed to lose 5 to 15 pounds, surgery and medications aren't really required. You can have a long-term 5 to 15 pound weight loss simply with diet and exercise. There's actually fairly minimal change with blood pressure, diabetes, and high cholesterol. These are common medical issues related to being overweight. And surprisingly, adding medications to diet and exercise doesn't really increase your weight loss or improve medical conditions related to obesity significantly. This is where surgery comes in. So who qualifies for weight loss surgery? Patients that have a BMI above 35 with medical problems related to weight, such as high blood pressure, high cholesterol, sleep apnea, or diabetes, would be candidates for surgery. If your BMI is above 40, regardless of medical problems, you would also be a candidate for surgery based on NIH guidelines. The 2 surgeries I'm going to talk specifically about are the sleeve gastrectomy and the Roux-en-Y gastric bypass. The sleeve gastrectomy is a restrictive-only operation. It involves reducing the reservoir capacity for the stomach. Essentially, if we tried to fit as much food as possible into the stomach, we could probably fit close to a liter of food at one time. What the sleeve gastrectomy does is it reduces the volume that the stomach can hold prior to the patient feeling full. Using a special stapling device, we longitudinally divide the stomach to make it the size and shape of a banana. That essentially takes the volume of the stomach down about 80% from its normal volume. The food that is eaten is then digested in the normal fashion. The benefits of this surgery is that there are similar weight loss results compared to the gastric bypass without rerouting the GI tract. Part of the reason this surgery works is some of the cells that secrete a hormone that makes you feel hungry immediately prior to mealtime are removed during this procedure. One of the cons is that part of the stomach is removed. This is not something that can be reversed. And patients that do have severe reflux can have worsening of their reflux after a sleeve gastrectomy. The national averages for complication rates for sleeve gastrectomy are listed here. In general, the mortality rate from weight loss surgery is very similar to elective gallbladder surgery in this day and age. Weight loss surgery today is very different than weight loss surgery performed 20 or 30 years ago, when patients at that time required large open incisions and usually 1 week ICU stays after weight loss surgery. Today, weight loss surgery is done safely and effectively, and most patients are able to return home the day after their procedure. You can see the weight loss curve after a sleeve gastrectomy in red. Generally, patients lose the majority of their weight in the first 6 to 9 months after surgery, and then the weight loss slowly plateaus after that, up to a year and a half after their operation. The second procedure I'm going to discuss is the Roux-en-Y gastric bypass. This is a combination of restrictive and malabsorptive surgery. Using the same stapling device we saw in the previous video, we make a small pouch out of the top portion of the stomach. About 2 feet down on the intestines, we divide the intestines with that stapling device and bring that portion of the intestines up to the pouch and sew those two things together. Essentially, the food that you eat travels down the esophagus, fills up a small stomach pouch, and then travels down what's called the roux limb to meet all the digestive juices and enzymes secreted by the stomach, pancreas, and liver, and then digestion proceeds from that point forward. This is still the gold standard operation for morbid obesity. Whenever there's a new operation that another surgeon invents, they always compare the results of the new operation to the results of the gastric bypass. And the reason this is done is because the gastric bypass has been performed since the 1950s. We've got the largest data set to compare this procedure to other procedures, and it's done safely with the greatest and most consistent long-term weight loss and improvement of medical conditions related to being overweight. Some of the cons of this surgery: it does require some rerouting of the GI tract and some lifelong vitamin supplementation. Some of the potential complications include leak, bleeding, and ulceration. Again, the mortality rate is similar to elective gallbladder surgery. The weight loss curve for gastric bypass is seen here in orange. As you can see, it follows very closely with the sleeve gastrectomy weight loss curve, in that patients lose the majority of their weight in the first 6 to 9 months after surgery, and then weight loss slowly plateaus after that. Generally, gastric bypass patients lose a little bit more weight than their sleeve gastrectomy counterparts. As you can see, as the complexity of the surgery goes up, the weight loss also goes up. But the most impressive part of this slide is the improvement of medical conditions related to being overweight. When including all bariatric surgery together, you can see improvement in multiple medical issues related to being overweight. These are similar medical issues that we saw on a previous slide earlier in this presentation. I'll highlight that sleep apnea, 74 to 98% resolved. High cholesterol, 63% resolved. High blood pressure, 70% resolved. Reflux, about 72% resolved. Something that is really impressive is the improvement in type 2 diabetes. And we see this especially in gastric bypass patients. Many patients that I've operated on, some of which are on 100 or more units of insulin per day, in addition to oral medications to control their diabetes, go home after their surgery with normal blood sugars without requiring any insulin injections. So even before these patients lose any weight, after a gastric bypass, they have improvement in their blood sugars due to hormonal effects from the surgery itself. So why have surgery here at Southside Regional Medical Center? We have a multidisciplinary approach. It starts here with this informational seminar where you learn about the different surgical options that are available to you. It continues at your surgical weight loss consultation, where we learn about your specific medical issues, eating habits, surgical history, etc. And we try to tailor the surgical approach to each patient. You meet with one of our dietitians, and they analyze your current eating habits and how they're going to change, both leading up to surgery and also after surgery. A psychological evaluation is required by many insurance companies to analyze your eating habits and also evaluate your support system. Many of you are going to require some medically supervised weight loss period. This usually means a waiting period that's mandated by your insurance company. If Financial counseling is available for patients that either don't have a bariatric rider that covers weight loss surgery or who have hurdles that are too high to jump over with their insurance company. We work with your subspecialists, your lung doctor, heart doctor, etc., to make sure everyone is on board with the plan prior to proceeding with surgery. We're also the only bariatric center in the Richmond area that offers both sleeve gastrectomy and gastric bypass via a robotic approach. It allows better tissue manipulation and visualization compared to standard laparoscopic surgery and less pain. And this has allowed me to work towards an opioid-free bariatric program. We currently offer both sleeve gastrectomy and gastric bypass using this technology. And again, we're the only hospital in the Richmond area that currently does both of these procedures robotically. What's surgery day like? If you're having a sleeve gastrectomy, it's about an hour and a half for your operation. Patients are generally up and walking that same day of surgery and are starting on liquids. The following day, or post-operative day number 1, we're advancing patients to a full liquid diet, and usually patients are discharged to home. The post-operative course is similar to a gastric bypass. It's about 2 hours for your operation. Again, you're up and walking 4 hours after surgery and starting liquids. On post-operative day number 1, your diet is advanced, and the majority of patients are able to go home the afternoon after your surgery. Our average length of stay is approximately 1.2 days, so the majority of our patients go home the day after surgery. Some patients that are having difficulty with nausea or tolerating enough fluid intake stay 1 or 2 additional days until they're ready to be discharged. It's important that you're staying hydrated post-operatively and also maintaining a high protein level in your diet for wound healing. And you're going to have specific instructions from our dietitian in terms of how to advance your diet over the next 2 to 3 months after your operation. Our post-operative visit schedule is usually at 2 weeks after surgery, 4 weeks after surgery, and then every 3 months for the first year, every 6 months for the second year, and then annual follow-up beyond that. During these post-operative visits, we're checking your lab work to make sure you're not getting deficient in any essential vitamins and supplements, and we make necessary recommendations and changes to your vitamin supplementation based on those labs. Most patients are out of work 2 to 3 weeks. It really depends on how strenuous your job is. For most of us that have sedentary jobs, we can go back to work about 2 weeks after surgery. Patients that do have strenuous lifting requirements may have to stay out of work up to 6 weeks after surgery until they're cleared to return to full duty. Most patients are on a multivitamin, a B12 supplement, and a calcium with vitamin D supplement. When we check your lab work for your post-operative visits, we can make recommendations to add iron, additional vitamin D, or other supplements based on your lab work. Patients that still have a gallbladder will be on a medication to help prevent gallstones from forming for the first 6 months after weight loss surgery, and patients that have reflux and heartburn symptoms may need to be on an acid blocker to prevent those symptoms and to prevent ulcers. But in general, most patients are just on a multivitamin, a B12 supplement, and a calcium with D supplement. Weight loss does increase fertility, so it's our recommendation that you avoid getting pregnant for at least 18 months after surgery, so as your vitamin levels can equilibrate and stabilize after surgery. This would also confer less risk to a developing fetus. So what can you do to prepare ahead? You can clean out your pantry You get rid of all of those high calorie and sugary snacks and drinks and restock with healthier choices and options. Experiment with different protein shakes. I'm often asked who has the best outcomes. The patients that are compliant or are following our rules have the best outcomes. It's easy to do that leading up to surgery. It's very difficult to get on the OR schedule and be authorized by your insurance company for weight loss surgery if patients are not following those recommendations. But the ones that have the greatest long-term results are the ones that are also following our recommendations post-operatively. Having a good support system and family support is helpful in having long-term success with weight loss surgery, and also avoiding trouble foods and exercising are essential components of long-term weight loss. So remember, you determine your level of success, and we'll be happy to let us show you how to get to that level of success. Thank you very much for your time, and there's a brief set of questions at the end of this presentation, and once completed, our office will be able to reach out to you to initiate the next steps. Thank you.